Michigan, and he received his MD degree from Northwestern University and completed his internal medicine residency at Cedars-Sinai Medical Center. He's completed fellowships in health services research at Cedars-Sinai and, very importantly, infectious diseases at the University of California, Los Angeles. Dr. Ryu has served as CMO and VP for Samsung, Senior Vice President and CMO at Lynx Health Incorporated, a clinician researcher at the VA Greater Los Angeles Healthcare System and at RAND. He's also been Associate Clinical Professor of Medicine at UCLA. He served on numerous boards and advisory committees, including those for the National Quality Forum's Executive Committee for Consensus Standards and Approval, as well as multiple device advisory groups for the FDA, CMS, and the NIH. So we welcome Dr. Ryu for his keynote presentation for this year's Quality Symposium, entitled Major Trends and Opportunities in Digital Health. And with that, I'll turn it over to Dr. Ryu. Welcome again.
Thank you, Dr. Weber. It's a real pleasure to be here. I oftentimes get asked the question, how did you become the chief medical officer for a large company like Microsoft, and even prior to that at Samsung? And it's a bit being at the right place at the right time, but it's also understanding some of the key trends that were happening in healthcare. And while it's difficult to sometimes find yourself in the right place at the right time, one of the things that we can do is we can understand the trends and the opportunities and get in front of that. And for me, it's interesting because for the big area that I identified early in my career was around quality and safety. In fact, much of what I was focused on was specifically looking at variation in care and ways that we could improve the quality of care, but through the use of evidence-based guidelines. Now, what's interesting is that very quickly transformed into something that was more than just simply providing information through guidelines, but was something that we recognized needed to be provided in the form of electronic decision support. And part of what I did in my career was try to figure out how it could get into the clinical workflow. And in that process, we developed evidence-based order sets. Ultimately, that became integrated into the electronic health record. And it really started a whole series of events where I started focusing on clinical workflows with evidence-based information, improving care, improving safety, but also the efficiencies, and finding ways that it works within existing healthcare IT infrastructure. Now, there's a lot of other things going on within healthcare that have emerged as major trends. And part of what I'd like to do today is talk about some of those and describe where we're heading, where the opportunities may lie, but also describe some of the challenges that we see, because sometimes with great opportunities, the challenges allow us to be able to understand where we may need to go deeper in, and we'll talk a bit more about that. So with that said, I'm gonna share some slides that will allow us to be able to kind of walk us through some of these talking points. And let me go to there. Whoops, can you see the slides? I presume so.
We see them well, David, thank you.
Excellent. So I'm going to touch on three trends that we have today probably been talking quite a bit about. At the same time, they also have an intersection with technology. And the first is around health equity. We can't really go a day without hearing about some issue that impacts us, oftentimes unrelated to healthcare, but also it impacts us in the context of understanding that these are patients, these are individuals, these are communities that are struggling with issues. And oftentimes we as clinicians need to play an active role in addressing them, because we oftentimes see the after effects of them. And what we oftentimes also have seen is that with technology, the expectation that individuals have of being able to have information, the right information at the right time, to be able to have a seamless experience. This consumerism is going throughout every industry, and healthcare is no exception. We see the need for us to have better experiences for patients, or seamless experiences, but that also extends to the technologies that we provide. And I'll talk a little bit more about what that translates to from a health IT perspective or health technology perspective. A big part of what we've seen during the pandemic was a rise of virtual care. There's been some that have estimated that 2 years of digital transformation have been pushed into 2 months. And so what we've now feel is that we have virtual care. It's a reality. In fact, we're doing something that probably years ago we couldn't have envisioned, having a conference, a medical conference virtually. But what we're also seeing is, in addition to just the video aspect, there's now an ability to bring in healthcare data into the virtual care visits, and how we can apply artificial intelligence and machine learning to make these experiences much more informative and relevant. And so as we think through these three trends, I'll provide some very specific examples of things that we are seeing in the industry that allow us to be able to understand where technology plays the role. So let's start with health equity. And health equity really is about trying to ensure that every individual has the opportunity to be able to receive the level of care and the quality of care that everyone expects. Now, simply providing equal care doesn't do that in many cases, because there are many factors that prohibit or inhibit individuals from being able to take advantage of that. And virtual care would be a great example. When we rolled out virtual care visits, what we found is that the people who took advantage of it had internet. They also had access to the clinicians, and they oftentimes had been doing things like this before. So there was a level of access, affordability, education, and training that was already there. Those that had not, whether they be because they've never been exposed to it or couldn't afford it or was inaccessible in the area, were left behind. And what we've realized is that if we want to provide equitable care, we really need to start thinking about how our systems are designed and where the systems need to go. Well, today, a lot of care is based on hospital and clinic. It's individuals setting up appointments, coming into the facilities that clinicians are in, receiving procedures and consultations, and then scheduling another visit to come back again to a similar type of brick and mortar facility. Now we're extending that to virtual care, so there's a little bit more extension into that. But for a good number of these folks, a lot of the care that needs to be taking place or better managed is outside of those visits. And we're really talking about the individuals that are struggling with trying to find access to the providers, but as well as dealing with issues that impact their day-to-day. And we can think of everything from the neighborhoods that they live in, the access to healthy food, the air, the quality of the air, the quality of the water. These are all factors that impact one's health. We also know that individuals suffer from other conditions that directly impact their ability to want to receive or are able to receive. Mental health, behavioral health is a prime example. And we know that there are certain environments in which it's just very difficult to be able to manage. And for that reason, the individuals that are actually providing most of the care are not in these clinics. They are the case managers, the social workers, the individuals that see them on a regular basis, and oftentimes are liaisons to understanding how we address each of these social determinants, social influences of health. Now, the challenge is that these individuals work in a system that's outside of our traditional one, not necessarily plugged into an EHR, oftentimes with really no electronic means. And a lot of this is being done on paper, or perhaps not even on paper. And so what we've realized is that there's a gap in terms of what we need to do. And this is something that needs to be addressed through broader public-private partnerships. And one of the things that has given us hope to understand how this can be put together is an effort that happened during the pandemic, in which when we started trying to get vaccinations into large areas, specifically cities and other areas, we started with the mass vaccination centers, but then very quickly realized that what we need to do also is to have these clinics available as pop-up clinics in parking lots and churches and other areas, so to make it more accessible. And accessibility was a big issue, and it continues to be a big issue. But what was missing, and the reason why we still have a high level of hesitancy across the country, is that there also needs to be a conversation. And that conversation has to be with a trusted individual who can deliver the messages and confidence that this is something that is worth taking. Now, we assume that that will occur with a clinical visit where the person coming into the office. But we've also seen that many people don't come in. And so these conversations have to be pushed into the community and brought to where people are. And what we realized in the process of doing these implementations throughout multiple states, countries, is that oftentimes the best way to do this is to have an event that is not COVID focused at all. Big realization is that people who are hesitant about COVID aren't going to go to a COVID event. It seems obvious, but it really is something that has been borne out again and again. But what they will go to is an event that is maybe a community event. We started with Cinco de Mayo and Mother's Day and Father's Day. We had other types of ethnic festivals. Return to work, or return to school was a big opportunity. And now more recently, in working with states such as Mississippi and Georgia, we're tying this into football games. And what's happening is, as individuals are going to these events for different reasons, family events, fun type of events, there's conversations that are occurring with local community leaders that have been empowered with the right information at the right time. And then not just the conversation, but then making the information or the ability for them to receive the vaccines right there. And in addition to the vaccines, doing what we know is necessary. So screening for other types of things that have been missed during the pandemic, looking at childhood immunizations, adult immunizations, cancer screenings, blood pressure screenings. And what we found was, by marrying a health fair with a fun community event, we could actually deliver care and try to create those bridges. Now, this is not just a one-time event, because the effect was essentially we wanted to continue to build this on an ongoing basis. So connecting them back into the local community health centers, the FQHCs, the local hospitals, enrolling them in insurance. I mean, there was a big part of that as well. But what we wanted to do is we wanted to start this process, and we've had some great results already implementing it in the state of Washington, California, specifically in the Central Valley with undocumented migrant workers, in Georgia, in some of the most diverse areas near Atlanta, and now Mississippi. And we've received inbounds already from the Dominican Republic and other parts outside of the US. This is a public-private partnership led by nonprofits. These are in organizations such as Easter Seals, and now United Way is leaning in on this, American Heart Association, local chapters that have trusted relationships with churches, schools, and other community members, but then connecting them to the hospital health systems, the local community health care providers, and public health, and then having a technology infrastructure that supports it. Because it turns out that when a person gets vaccinated, you've got to be able to capture that and send it to the state immunization registry, and sometimes into the electronic health record. It's got to be secure. So there's a role for all three. And what we found is that this model in many examples has led to some great success. Just a couple of numbers, some of the more recent events that we've hosted: 400 people attending, a third of them getting vaccinated, more than just vaccinations, but blood pressure screenings, cancer screenings, insurance enrollments, the follow-up visits, 98% follow-up in some of the visits in undocumented immigrants, extraordinary level of follow-up, and 2 to 3 times more people attending the second events because they were inviting their family and friends into these. So a lot of learnings. It's part of something that, if there's further interest, please feel free to reach out to me. It's called the Vaccination Equity Consortium, and it's something that we feel is a model for how we can deliver care, but through public-private partnerships. And as we start talking about engaging patients where they are, in their homes, in their communities, we also realize that there's a lot of technology that they use. A lot of these technologies are things that we can take full advantage of as we start looking to expand our ability to provide care. So consumerism, our ability to be able to leverage the consumer devices and the technologies that they use every day to provide information, but also to capture information. And as we think about this, one of the things that oftentimes gets forgotten about, because we're so fascinated with the latest sensors and the ability for us to be able to move that data into different areas, is the fact that the data itself needs to be made interoperable to make this all work well. Now, there's a bi-directional element to this. The data that's captured from, let's say, wearables, needs to be made interoperable. Some of the things that we've been doing have been developing FHIR connectors for the IoMT, or Internet of Medical Things. So data from wearables can then be brought into a mechanism where it can be brought combined with other types of FHIR-enabled data sets. But on the other end, bringing data out of the electronic health record to consumers. And as we think about that, that has really been one of the major trends and opportunities for how we can rethink how healthcare is provided. Now, a large part of this came about with the 21st Century Cures Act, and then the subsequent CMS interoperability rules, which have now given us the ability to see how FHIR standards implemented universally by electronic health record vendors, healthcare providers, payers, allows consumers to be able to gain access to their medical records on any device or technology of their choice. That's a foundational piece for what we are now seeing within COVID, whereby information for vaccination status and test results, which are a good number of states and businesses are requiring some level of validation or verification of this, that information can be made FHIR enabled. One of the key initiatives that we've worked on, and in collaboration again with several organizations, including healthcare organizations, EHRs, and businesses, is to create a Smart on FHIR application that allows us to be able to take information and convert it in a way that is understandable and readable through a barcode, essentially, that can be then transferred onto individuals' devices or even on a piece of paper. But what we're essentially doing is we are leveraging the exact same process that we use for FHIR for consumers to gain their access to the health records. But this is a subset. This is the vaccination status as well as the test results. And what makes this unique and special is that there is a verifiable process now. So it's no longer just an electronic version, but there's an ability, once that version is read, to know that this came from a verified source, whether it came from the healthcare provider, the electronic health record, a certain state immunization registry, et cetera. And this is the next step of where we see the pandemic heading towards verifiable credentials, leveraging FHIR, and several states already have adopted this and will continue to see more. But also great opportunities for us to start thinking about when consumers start gaining greater access to their health information onto their devices, starting with the vaccinations and tests. It gives them an opportunity to be able to then receive services from organizations that can develop those services and provide value. So again, major trend that is allowing us to be able to understand where the opportunities are. If we think about what we are seeing in terms of how care is delivered, it largely started with in-person clinic and hospital appointments. But what we are now recognizing is that virtual care is a mainstay of how we can continue to do those visits. This is something, though, that today is oftentimes still periodic. There's remote patient monitoring that allows us to be able to continuously access information, particularly biometrics. Then there's text messaging. Now we've seen the implementation of other types of tools such as AI-based chatbots and other interventions. So I want to talk a bit about that progression of how we are along the journey, adding more touch points for us to be able to understand how an individual is doing so we can better manage and expect whether or not they're heading in the right direction or not. And largely, it's based on the concept that to better take care of an individual, you need to know more about them, and you need to have, we'll call it a 360-degree view of all the issues that they're faced with, but also where they are on their journey. I oftentimes like to think of this in terms of, probably not an appropriate analogy for the healthcare, but a pizza. If we think of all the circle in the middle as multiple different components on that pizza, that upper left-hand side is really about understanding the individual. And this is about capturing data from that individual along those multiple different touch points. Again, we have it through the electronic health records, but remote monitoring is helping us, virtual care is helping us, and then even patient-reported outcomes and surveys. This is giving us greater insight. We also know from the genomics that there's a significant amount of information. We know from their zip code, that's a significant amount of information. And we also know that there's a lot of other types of variables that we haven't yet captured that need to be brought into this. But that is the understanding of the individual. The next, if we move to the lower part of that pie or pizza, is the opportunity to then apply advanced analytics and artificial intelligence and machine learning onto this to make sense and be able to be much more predictive of that. This is where there's been an explosion in terms of technology and capability so that we can do so much more than simply dashboard it. And I'll talk to you about some of those amazing technologies that have given us greater opportunity to transform that data, those new data sets, into something useful. But then at the end of the day, if we move to the upper right-hand part, it's about people acting on it. Again, the right information at the right time so people can act on it. And that means that we have to coordinate care. We have to make sure that information is presented to the right individuals so that they can act on it. And I'll tell you what it's not. It's not about sending alerts to doctors within the EHR or within any system, because that is oftentimes something that will create a lot of noise and is not workflow efficient. And so what we're looking to do is we're looking to leverage the entire care team, understand who needs to be notified and how we can then allow every individual to practice at the top of their license. And to do that, we need an infrastructure that supports this. And this is where there's been significant amount of work to understand how these different data sets, if you look on the left-hand side, EHR being FHIR enabled, imaging, DICOM imaging being FHIR enabled, genomics and proteomics and other areas that give us greater sense being FHIR enabled, third-party data, more specifically social determinants of health and social influence of health, Internet of Medical Things. This is all needing to be standardized, and FHIR is serving as a great opportunity for us to be able to develop that. Now, keep in mind, FHIR is not a one-time standard. In fact, it continues to evolve, and we see versions that continue. Right now, we're in version 4, but we're going to continue to see versions that go beyond that. And what we need is a continuous assessment and understanding of how the FHIR standards evolve and expand. But then once we get into sort of that middle part of where that data is being captured and normalized, artificial intelligence that gives us greater understanding of what needs to happen then needs to be pushed out to the different tools. And the tools we oftentimes deal with are electronic health records, because that's oftentimes the world that clinicians are focused on. But as we think about this broader ecosystem, it's now going to include tools that involve everything from a dynamic CRM system so that a case manager can be accessing this using tools that cross the care continuum. This can be done by receptionists and even call center agents. It can be done through mobile phones and texts and a variety of other mechanisms. So what we're seeing is this process of data, multiple different data sets, normalized, analyzed, and acted upon. So let me give you an example. So as I think about one of the things that is probably one of the more common events that happens in healthcare, it's an individual has an issue. They either go to a website, or more often than not, they pick up the phone and they try to schedule a phone call or an appointment. That happens every day, all the time. Now, the reality is there's a missed opportunity there. And the missed opportunity is if we knew, and let's imagine I make this phone call, I'm trying to set up an appointment, and that I've missed my last 4 appointments. So rather than just looking for the next appointment and scheduling it, I should have been flagged as high risk for not a no-show. And this impacts everything from showing up to an appointment to showing up for a procedure, which could have even greater implications. But what we're looking at is we need to know the history of the individual, the challenges that they have. If I knew that, and a chatbot can actually, using a FHIR API, pull that information seriously or seamlessly, and then run an algorithm that could be presented to the call center agent or the receptionist, that would then be, the person would be prompted to ask, hey, I noticed you've missed your last 4 appointments. Did you know that we have transportation programs that we can offer? Would that be helpful? We also have vouchers. Oh, and by the way, it looks like you're eligible for a virtual care visit. Oh, you've never done that before? You'd like to? Did you know that we can actually set that up right now? And so bringing programs and opportunities to the individuals, but at the right moment, can be done and facilitated through chatbots, which is a very unique way of thinking about chatbots, because typically we think about it as simply a consumer device that provides information and then gives you some sense of what you need to do next. This is now a decision support tool for the rest of the healthcare provider system. And it can be then integrated into existing systems. This is an example of a Dynamics CRM system, which has, we'll call it a clinical decision support area called Smart Assist. And this is exactly what's happening. It's pulling data and it's providing guidance to the non-clinicians to provide and follow standardized protocols based on information. Now, what you can also do with these chatbots is you can do a virtual handoff to a telehealth visit. We saw this during the pandemic. A large number of individuals wanted to, they needed to have a visit or some kind of evaluation, but they weren't someone who needed to be coming into the hospital. Perhaps there was a concern that they actually did have an infection, but were not sick enough that needed to come in. So these consultations needed to be done virtually. Much of virtual care today has been about a video visit. So that is kind of what we're doing here, a bit of a video visit. But in a clinical visit, there's more to it than video. In fact, one of the most important things is we need to know the context of your medical record. So pulling up your medical record, not having it on a separate screen, being able to show you the last lab results and be able to identify that. If I'm going to then do a collaboration and bring in a consultant, that consultant's going to need to know those lab results, perhaps see the X-ray or image, a CT, and this ability to use FHIR APIs, pull the images directly from the EHR, surfaces it up, that provides a new opportunity. But then now what we can start doing is as data starts moving in and we start capturing data, we can apply artificial intelligence to it, not just unstructured, but also on unstructured data. So I want to give you 3 examples of how virtual care is being combined with artificial intelligence and machine learning to create these new experiences. So this is the first example, something that some of you may have heard of. It's called ambient clinical intelligence. It allows us to be able to convert voice to text, but more importantly, understand the context of that, convert it into a progress note, and then integrate it into the medical record. So I'm going to just run the quick video and this will hopefully explain a little bit more. Oops.
You don't become a doctor to bill. You become a doctor to take care of patients. You become a doctor to serve humanity. Ambient intelligence allows for the patient and doctor to be a patient and a doctor, like it used to be.
There's a certain business requirement for a structure.
Whoops, sorry about that. Let me try that again.
You don't become a doctor to take care of patients. You become a doctor to serve humanity. Ambient intelligence allows for the patient and doctor to be a patient and a doctor, like it used to be.
There's a certain business requirement for a structured note and careful documentation, precise diagnoses, and carefully backed up coding for the business practice of medicine. But ultimately, it's about the patient's story.
If you look at the promise of meaningful use and all the reasons we got into a digital health record, it really was to take better care of the patient. Unfortunately, sometimes we've done that through a barrier, meaning we added a keyboard, we added a computer, and I think that's a key part of why physicians are frustrated.
And I mean, you notice as a patient, you notice that your physician is typing and talking and, you know, yeah, okay, yeah.
Now we can go into the background and just capture all the information you needed, but also maybe more importantly, capture something that was missed. That missed was the patient's story.
There's a device on the wall and it's listening to your conversation and it's able to discriminate between a patient and a physician and a family member and is able to generate a progress note and a patient encounter based on your conversation.
What it has enabled is that I can pay attention to what you are saying, because it is very important for me to have the empathy and you to feel as a patient that you are telling somebody who actually cares about you.
Hey, Dragon, start my standard order set for arthritis pain.
The idea of a computer that can listen like in Star Trek and just hear what's going on and make sense of it and slip into the background and listen, but only interject when necessary. That was for a long time a fantasy.
I would say before, in a typical week, I would probably spend 6 to 8 hours documenting, just simply dictating and signing notes. I bet that my time has been cut into half, if not thirds, because of nuance now.
It takes the hands-on time that the provider has to spend with the computer and puts that time back with the patient.
It really takes a lot of that manual work out of the patient encounter and just allows it to happen kind of naturally.
Ambient puts a listening device in the room quietly, securely, privately, and allows the two people in the room to really have a very intimate discussion on very private things. Knowing that the necessary recording of that for the business of medicine and healthcare can go on in the background, but letting that personal connection continue. And that's the reason I think almost all of us went into healthcare. It's to be able to be there for people, to express caring, to express empathy, and to connect as human beings.
So this technology is something that has been tested for multiple years and is now brought out as an actual live offering. I was just yesterday or this past week spending some time with the senior leadership at the Mass General Brigham. They've been using this and they shared with me their numbers are even higher. They have about 80% reduction in the amount of time it takes to enter documentation into the EHR with this. So this has been really one of the rare opportunities for us to see how we can greatly enhance the user experience, the clinician experience in the EHR with the use of these AI-based technologies. This is also now something that can be done through a virtual visit. So if you are, let's say, seeing a patient virtually, what we can now have is that entire conversation, similar to what we saw, captured, voice to text, organized into a progress note. You still need to sign off on it because then it gets pushed directly into the medical record. Really an extraordinary opportunity for us to kind of rethink how we can improve care. Well, it starts with efficiency, but by understanding the context of these conversations, we can start thinking about how potentially clinical decision support can be built into this system as well. So let's move on to the next example. The next example is about how we can start thinking about how information that is oftentimes perhaps on the internet or something that we have not really been able to get a full understanding of is brought to the forefront through the use of text analytics. When you think about all the medical literature and then you add on top of that information within large databases, it's hard for us to be able to make decisions quickly. Yet at the same time, we're oftentimes asked to. A great example would be in cancer care, when you have these multidisciplinary teams all meeting together to talk about what's the next best treatment option. A lot of information is being presented and discussed. And a lot of times we want to do is synthesize all of that and be able to provide a very specific recommendation. I'm going to show you an example of how this is being used, natural language processing, specifically text analytics, to be able to help improve patient care, specifically during the virtual tumor board session.
We're all touched by cancer in one way or another. Every cancer is different. Tumors can have hundreds and thousands of cell mutations. How do we find that one change that we can target and treat that cancer?
There's millions of scientific articles covering specific mutations and combinations with drugs.
We can't possibly keep up with all that literature.
The clinical knowledge base is an innovative technology where all those variants, mutations that exist in cancer are being curated as they're discovered by researchers around the world.
That's where our collaboration comes in with Microsoft AI to help us triage the literature. Machine-assisted human curation can assist going through all of those publications and saying, this is one, so that the team can use their scientific expertise to interpret them.
It's a life or death situation. It's also a question of how you accelerate certain discoveries and bring them into clinical practice. We have a stage 4 esophageal cancer patient who's 60 years old.
We can more accurately predict patient responses to a combination of targeted therapies, immunotherapies, and even drug resistance. It is that funnel to be able to get to the right mutation with the right treatments associated.
With Microsoft AI, oncologists will be able to improve patient outcomes.
Every morning I wake up to fight cancer. Through the collaboration with the Jackson Laboratory and Microsoft AI, we can know that we haven't missed anything. And it's just been wonderful.
And the third example I wanted to share is specific for
We're
how,
all touched.
how this information can be brought, this artificial intelligence, the data, to a different, we'll say, device or different way of looking at the world. Thinking of GPS, having a GPS system with you anywhere, everywhere, but now in this example, within a surgery, within an operation. So why don't we take a look at the video, and I think you'll get a better sense of how this could work.
Today, HoloLens 2 is transforming our daily practice in surgery. It meets two objectives: ensuring maximum safety of the surgical procedure and optimizing the quality of the patient care. For example, I can communicate with other colleagues such as radiologists, infectious disease specialists to get their opinion during the surgery. And it is well known that this multidisciplinarity considerably improves patients' management. The great strength of this application for HoloLens 2 is also, and above all, to provide surgical guidance. From the patient's CT scan, a 3D model of the skeleton is reconstructed and integrated into an application. HoloLens 2 and this application automatically calibrate the skeleton hologram on the real patient. The areas hidden by the skin then become visible. And it is possible, for instance, to define the perfect axis of the pin to be introduced into the patient's skeleton. It's like having augmented eyes, allowing the gesture to be even more precise. The scrub nurse also benefits from this application, which details each step of the surgery and the associated instruments. Easy access to this procedure reassures the scrub nurse and makes he or she much more efficient. The goal is also to collect all the data from the surgery, but also from the surgeon during all these surgeries, for processing all this data in an artificial intelligence center located at Sorbonne Université Paris Nord. The ultimate goal is to model the perfect surgical gesture. HoloLens 2 offers a fantastic field of possibilities that currently transform our practice every single day.
So what I've shown you are three examples of how virtual care, when combined with artificial intelligence, can completely transform the way that we think of how care is delivered, the opportunities for being able to understand and be better guided to deliver better quality and better experiences. Now, another area that we have also seen opportunities lies in the fact that we're capturing biometrics from individuals. These are just a list of some of the biometrics that we have available today, but the list goes on. And these are through wearables, other sensors. They could even be through implantable devices. But what we'd like to do is we'd like to go beyond what we can currently do. This is an example of what oftentimes is done when we get the data. We've got a dashboard. We've got different types of things for each patient. You can see trending over time. You could perhaps put some upper and lower bounds, some alert thresholds on this. But the reality is that's not how clinical care is typically done. I don't really have as much interest in understanding if an individual heart rate went over a certain number or if they had a less or higher number of steps. What I'm really more interested in is how all of this information can be brought together to tell me, is this person getting better, worse, and should I intervene now? Now, this is something that we actually have done in the past, but not necessarily through technology. I'm an infectious disease doc, so a lot of my early work was around communicable pneumonia. And as most of you remember, and probably even still use today, that we have a prediction rule that predicts 30-day readmission and 30-day mortality rate, I should say, with a fairly high level of accuracy, using variables that are things that can be oftentimes captured at the time of admission or at the time of encounter. Age turns out to be the most important risk factor. You get 1 point for every year of age. Now you subtract 10 if you're a woman because of just lower risk overall, but you add another 10 if you're a nursing home. Now, the comorbidities, we oftentimes think you need all these different comorbidities. Well, based on multivariate analysis, it turns out that there's really only 5 that matter. And there's a slightly different weighting where cancer gets highest weighting on that. Physical exam, lab findings, again, certain number of findings that you get a certain number of points, you add them all up and we got a score. And that score has given us an ability to start thinking about how we can understand, is the person heading in the right direction or the right time? This is a quote from one of my favorite movies, Moneyball, because if those that haven't seen it, it's essentially about trying to understand which type of players you can bring onto the field to get to the highest probability of winning a baseball game. In that scenario, what they do is they take multiple different statistics and they boil it down to one number. And that boiling it down to one number is essentially what we're doing. We're trying to create these indices of harm, of risk, of mortality, and allowing us to be able to understand where those individuals are. Then we can map them in coordination with other individuals just like you. So if I want to, I'm curious about, and I may not know because there's no studies on this, individuals that have had COVID, that have a certain number of conditions and that are experiencing a certain type of maybe oxygenation level. What's their prognosis? Do I need to be much more aggressive, less aggressive? Can they be managed at home? All these questions come about. But in these cohorts, we have now an ability to understand how they're doing and then predict where they're actually going to go. And that is one of the great opportunities where all this data is being made interoperable and allowing us to be able to apply these AI and advanced algorithms on top of it can give us a sense of becoming much more predictive and proactive. And that is allowing us to start rethink what's possible. So I've given you 3 examples. I've talked about major trends in health equity, consumerism, and virtual care combined with artificial intelligence, and the opportunity for us to apply technology in the form of public-private partnerships, clinical decision support that goes to extended care providers, and various types of natural language processing and tools that give us greater insights and guidance will allow us to be able to take advantage of those trends, convert them into things that can be meaningful and actionable. So with that, I am going to pause and see if there's any thoughts or questions, and we'd love to kind of open it up for Q&A.
Thanks very much, Dr. Rue. We really appreciate the presentation, kind of a dazzling look into what might be ahead. And we will open up to questions now. I'll encourage folks to use the Q&A function at the bottom of the screen. I believe the audience can also raise their hands, but I know there was at least one question that came in, a couple now coming into the presentation. I'll just restate. I know there might be folks just listening by audio. So Dr. Rue, can you address the honest broker issue? And this comes from Dr. Davis, who's our department chair in quality for the Department of Medicine. But can you address the honest broker issue? How can we limit well-heeled, self-interested parties from pushing very expensive therapies of marginal benefit? Will this turn into direct consumer marketing on steroids, adding spending patterns, biometrics, genomics to health conditions?
That's why we need folks like you and all of us to be looking at all the issues. I think what we find is there's so much opportunity when we roll out technology and implementations without thinking about the secondary effects, the implications. We will potentially cause harm in some populations. And that is why when we think about artificial intelligence, we think about the ethical use of artificial intelligence. We think about the fact that were they built using a comprehensive set of patients that are representative, diverse, and are things that we potentially, if we haven't, how do we encourage enrollment? This gets to health equity, this gets to understanding implications. And a lot of times what we do, and this is something that we are also actively engaged in, is we have to study. We may have done all the pre-work up in advance and thought as much as possible, and we have to study the effects afterwards. Because a lot of times we don't anticipate. These are things that, again, unexpected, unanticipated consequences of rolling it out, and then we need to adjust. And so this process of the comprehensive evaluation, development of the algorithms and technologies, implementation, followed up by real world data and real world evidence, and then a feedback into our ability to understand and how we need to adjust. In some cases, what we may end up doing is we may adjust the algorithm. Other cases, we may say we need to carve out a separate type of algorithm or approach for these different populations because it's creating greater disparities. During the pandemic, what we realized is with virtual care, some of the big issues were around lack of access to broadband, affordable broadband. So to do that, we realized that we had to also address that. So Microsoft leaned in, and working across the nation, we've been working to improve access to affordable broadband. Right now, over 1.4 million individuals have been, through these public-private partnerships, able to receive it. Globally, about 14 million. And this has been an extraordinary opportunity for us to be able to identify gaps and then work together to solve them. But great question. I love it because it really gets to the heart of why we need clinicians driving this and not just simply on the back end receiving it.
I appreciate that. There's a couple of other questions that I might say are on maybe a similar thread. Dr. Puri had asked about, can you speak more about how health literacy and digital literacy need to be addressed? And then extending it, Dr. Huang had asked, what do you see as the most important barriers to achieving the world? And he mentions as well, tech literacy, fractured nature of the health system, cost of adoption. Maybe you could stay on that theme for another moment if you could.
Yeah, absolutely. I'd say with digital technologies, probably the first thing is just simply access to it and making sure it's affordable. So access and affordability, those two things are probably step one. But then the second piece is once they have access and affordability, there's a level of digital literacy, and then there's a level of understanding healthcare literacy. And so we've got two things that we have to be done on top of that. We have been actively trying to engage organizations. And what we sometimes find is that sometimes it's impossible or not practical to educate everyone to the level of like a virtual care visit. It would be sometimes for some people, it's just not possible. So the default is, well, you have to come in. Well, actually, the other option is there a process where we can surround those individuals with support services, basically have people come in, set it up for them. Let's look at the caregivers. Let's look at the extended care team that we have out there that are interfacing with these folks. We've been working closely with partners that are looking to deliver those type of concierge, real, hands-on type of touch services, and also finding ways that they can work directly with caregivers, could be family members around this. So let's leverage the entire team to try to solve this. It's oftentimes not something that, relying on the patient to be able and expecting them to be able to solve this is going to be practical. We have to be reasonable in our expectations. And then in that context, I think what we'll find is that we'll be able to expand access to this technology to a broader group of individuals.
Thank you. I feel like you might be deftly reading ahead some of the questions because you're sort of moving from one to the next. One of our leaders in pharmacy asked just about that, about your thoughts on how all these technologies can break down silos and facilitate team-based care. So again, you're sort of heading down that path, and maybe there's a little bit more we could say.
I am a firm believer in team-based care, and I am also a firm believer that the physician is a part of the team, but shouldn't own all the responsibilities. A great example, early in my career, I had this question of, like, when we look at vaccination rates, specifically pneumococcal vaccinations, this was in the VA, we had about a 20% vaccination rate. And I said, well, that's weird. Why is that the case? And of course, I knew the answer, because you're busy. A person comes in, usually they're not there for a pneumococcal shot, they're there for some other reason, and it's not something that you even think of. Even when you do think of it, you're saying, well, maybe it's not the right time now because the person's coming with a heart attack. I don't think I necessarily want to give, or a chest pain, or a GI bleed, or some major issue. I don't think I want to bring this into it. I'll do that the next visit. And sure enough, it's completely forgotten and missed. So this coordination of care is so essential, and understanding who needs to do it and when you need to do it. And what we've realized is that oftentimes when you have that missed opportunity, that second opportunity doesn't come around in the same way that we would have anticipated. That's why we have to start building out, I'll call a more structured pathway or a plan or a patient journey, so that when there are touch points, that these things are not forgotten about. It shouldn't necessarily have to be reliant on the physician's next visit. It could be on the follow-up call that is being done by the nurse to the patient or the pharmacist to the patient. It had nothing to do with this particular visit, but the healthcare system was engaging in this process. And what we've been doing is, if we think of CRM no longer just as a means to do triage and understand where individuals need to be scheduled, but what we think of it as a platform that allows us to be able to pull this type of information and present it real time to individuals across the entire care continuum. You've got now an ability to, again, provide the right information at the right time. I think these are all the interesting and exciting areas that we're exploring right now, that we have new platforms that we can provide this. We always thought that it had to be electronic health record, but with most of the care that's provided is provided by individuals outside of the EHR workflow. And it's, you know, it could be a call center, it could be a visiting nurse, it could be a case manager, it could be a home care provider. And those individuals need the right information at the right time. So we need to figure out ways to empower them with that and make sure that these opportunities aren't missed.
Great. We have another question from Marina DePablo, who's one of our leaders in patient education, experience, and engagement. Could you address strategies to increase patient trust, and particularly regarding integration with AI? And I'll take the moment to pile on to that. And especially in the context, we know that even before we add in the AI, you know, we serve, and so many people serve communities who experience well-earned mistrust and health system and that. So how do we add this extra nuance on, and how do we address that to make our patients feel more comfortable and our community feel more comfortable?
Well, there's two aspects to that. And I'll touch on first just the general issue of trust with a particular, it could be a vaccine, it could be a process, it could be an algorithm. It has to be delivered by individuals who are trusted. Now, you would say, well, a physician's trusted, but oftentimes we don't have an opportunity to have physicians in front of every patient talking about these type of issues. What you really need to do is we need to start thinking about how we empower trusted members of the community to be able to communicate these messages. And that is exactly when I talked about the Vaccination Equity Consortium, is what we have tried to do. We've tried to identify the local leaders. These are churches, schools, community health leaders, or not even health, just community leaders, but empower them with the right knowledge and information that allows them to be able to articulate to their members, their friends, their colleagues, their community neighbors, why this is important and how they can act on this. That is sort of at a general level, you know, so make sure that we find the right people to communicate this. Now, what they're communicating also has to be something that has been done with, I'd say, a broader sense of community and diversity. The good news is that in the development of the vaccinations, they included broad ranges of individuals. It wasn't just done on, you know, the traditional clinical trial is whoever signs up. You know, a lot of times these are middle class, upper class individuals that have the time and ability to be able to receive. I mean, what we have to do is when we start at clinical trials and evaluation, make sure it's inclusive and representative of the populations that we serve. That is so absolutely critical, because the information, the results that come out of it, whether it's a vaccine or whether it's AI algorithm, are going to be deployed generally, broadly. And that immediately will create a sense of distrust if it was not tested or developed in communities and individuals that look like me and have gone through the same type of experiences. If we know that's been done, and we can confidently say that this is something that we have total confidence that it is safe, it works, and it is effective, then that is where we can then continue to leverage the fact that we've got trusted individuals. So it's really both. You need the messenger and the message, but also you need to have the underlying infrastructure that we can all rely on.
Well, I know we're close to the end. I'm going to combine the last two questions, but as I do so, I'll just remind the audience, as folks need to step away, Katie will post the CME link again on the screen. And David, I hope that's okay as you feel the last question.
Sure.
But then also invite folks, remember we have the final poster session this week for the Quality Symposium virtually at noon. And then at 1 o'clock, the award ceremony. We look forward to seeing all of you there. And I'm combining the last couple of questions, if I might, for a moment. One from David Beiser, who's one of our clinicians and an innovator himself, and Graham Ossie, who works in the space of digital health, helped lead our own programming on that. And the questions are perhaps related. From David, can you address your thoughts on business models for supporting some of these on the continuum of care services beyond the pilot study? That's sort of at the local level. And then Graham had asked, what do you think about how we need to look at business and financial incentives to change healthcare and drive some of these changes? So sort of a micro and a macro framework of how we're going to support this.
Yeah, and they're touching on probably one of the core issues of how and when digital transformation will occur. There has to be a driver and it has to be sustainable. So financially, there has to be some alignment. What we have found is that clearly value-based care is a driver, but that is not necessarily in itself the only thing that will drive opportunities. In fact, if solutions work within a fee-for-service world, then it turns out that that actually is something that people will act on right now more broadly. Regulatory is huge. I think many of us are still waiting to hear whether or not once the emergency authorizations for and opportunities to apply telehealth will be extended or whether they'll be released. These are all important variables. So policy ends up becoming a huge aspect, policy and reimbursement. I mean, sometimes you can have the right solution and it just necessarily isn't the right time for that. A large part of it is driven by regulations, penalties, incentives. And I know that there are opportunities within the current context, specifically as we look at things such as Medicare Advantage, MA populations, significant opportunity where it aligns value-based care and some of the broader things we're looking to do. That tends to be a huge opportunity. But I also think that the other area is just in terms of patient engagement and enrollment. If you think about it from the perspective of a hospital or a payer, the only way you're going to get paid is you have to have patients. And it is a fierce battle to win patients over. So how you win the battle of getting patients and consumers engaged in your system and the programs that you have, that's the front end battle. So that's why consumerism is such a big part of how we do this. And now we're adding the level of community engagement. If you've got partners in the community and you've got the tools and you've got the different strategies for how you get people in, and now they're brought in and you've addressed some of those social determinants that'll bring them in, you have an opportunity to tap into other markets that you perhaps may not have been, like Medicaid, which is oftentimes viewed as a losing opportunity, but in the broader sense, there's still opportunities out there. So I think that a lot of times we don't necessarily go deep enough to understand where those opportunities are, but there are tremendous business opportunities out there for entrepreneurs as well as for healthcare organizations.
Right. Dr. Real, I want to thank you again for really an exceptional presentation and for your handling of all these questions. And you can get a measure of the engagement of the audience by just that sliver of questions that we're able to get to. I'm sorry to those for whom we couldn't get to your questions. Dave, I hope at some future date we can bring you back onto campus in person for even more time together. And we really look forward to one day when you need to ask our permission to use examples from University of Chicago where we've applied some of these skills and innovations inspired by your remarks today. So thank you again for serving as our keynote presenter. Thank you to the organizers. And we look forward to seeing you all at 12 for the posters and again, 1 o'clock for the award ceremony. Thank you all so much. Thank you, David.
Great, thank you. Have a great weekend all. And thank you, David.
Thank you, everyone.
Quickly, people, Lily, that was exceptional. Really thought-provoking. Thank you so much.
Great, thanks. It was exciting. I had a little bit of a technology glitch in the middle, but other than that, things went great.
We're really grateful. I'm going to need to get over to another, but and I don't mind those who are still lingering from the audience to hear. We're just really incredibly stimulating and aligned in ways that you wouldn't have even known in terms of where so many of the group are thinking. So thank you so much.
That's fantastic. It's funny because as I shared before, my journey started with quality and safety. So this is really the origin of where a lot for me personally, where I've been, but I definitely see how technology is just huge enabler. Everything that I share, there is an element of quality and safety that is a part of that. And we just have huge opportunities in front of us.
Right, exactly.
Thank
All right,
you.
I have to jump to. So thank you
Yep.
again. I will be in touch and really appreciate the time this morning and the time that you put together this proposal or this presentation as well.
Wonderful. Thanks,
And
everyone.
yes,
David, be
all right,
well.
take care.
Bye-bye.
Thank
Bye, Katie.
you.
Thank you.
Bye.
Bye. Thank you, everyone.